Tonight, we focus in on how the NHS is organised and funded. Tonight's proposition comes from the political commentator Andy Maciver.
If you've used the NHS recently, you'll probably have realised it isn't working. I think we need to look to our friends across Europe to figure out how to fix it. We put in a similar amount of money as they do, but we've had poorer outcomes on key killer illnesses. We have fewer doctors, fewer nurses, fewer beds and less machinery. Like us, European countries have health services based on universal provision paid for by taxpayers, but they top up with co-payments, so those who can afford to pay more do pay more, leaving more in the pot for those who can't. In this country, we wrongly call that privatization, but in those countries, they call it egalitarian. It's time to wake up and grow up. We have a 20th century health service in a 21st century world.
And Andy joins us to debate his arguments with Dr. Chris Williams, who's Joint Chair of the Royal College of GP Scotland. Thank you both for joining us. So, Chris, you've heard Andy's argument there. What do you say in response?
So, firstly, it's important to recognise that we need to be talking about our health service, how it's funded, and what changes we need to support it. I don't think that anyone believes that we can continue on exactly as we are. Even as we recover from the pandemic, we need to be thinking about what can be done differently or what we need to keep the same. So I'm very glad that we are at a stage to be able to think about solutions, to think about systems that are in place elsewhere and whether they suit us in Scotland.
And would it suit us in Scotland for some people to pay a bit more, Chris, which is Andy's proposition?
No, it would be my short answer. So I would go to a more extended explanation about why that is. So co-payments we do have in some parts of our healthcare system, in dentistry, for example, and we know that system is very far from ideal and that there are particular issues around access. Co-payment won't solve the main difficulty in general practice, for example, where the main problem that we face is a lack of general practitioners. And while we know that it's a system that operates in other parts of Europe, in other parts of the world, that we also know that when we look at the evidence round about the co-payments, there are some problems with it, especially around about access and about when people seek healthcare.
OK, Andy, well, Chris is saying that it wouldn't work. It's not a great model for Scotland. And in practical terms, how would it work? How would you assess people's ability to pay? You know, who has to contribute the top-up payments? Is it about wealth or income?
Well, I mean, I think that Chris and I are probably actually not too far apart on this. I don't think it's by any means the ideal system to effectively have private healthcare and co-payments in that sense on top of what we've got just now. It would have to be a stepping stone to a better Europeanised model. I mean, the key issue that we have in the health service, whether it be primary care or particularly in hospital care, is a lack of capacity. We don't have enough doctors, we don't have enough nurses, we don't have enough beds, and we don't have enough machinery. And you know, the stats don't lie. We put in slightly more than the OECD average, but we get slightly less back.
Andy, bringing you back
from that.
But bringing you back to what I'm asking in practical terms, how it would work. Chris says they've tried it in some areas of dentistry, and it's very difficult.
Yes, and in Europe, what really happens is that the capacity problem you see doesn't exist in the same way in Europe, because in Europe they have much more diversity of supply. They don't have a single nationalised supplier of healthcare like we have. So in practice just now, it would rely on employers or individual people, which is happening anyway. It's happening all the time, especially post-COVID. It would rely on people who are able to do so to effectively pay a little bit more towards their healthcare and go private. Now, I don't think that's an ideal model at all, but I think it would be a way to potentially reduce a little bit of the capacity issue in the health service. Part of the problem as well, of course, is that private practitioners in this country are also NHS practitioners. But
Andy,
so the capacity issue doesn't always get...
But how would you... I'm struggling to understand, how would you determine who was actually going to pay? Would you pay?
Well, I would imagine it would be that. The point I'm trying to make you see is that at the moment, because we have this nationalised supply system, it would be actually people themselves and employers themselves who would have to decide to offer this. I don't really want that as the permanent solution. The permanent solution is moving to a Europeanised model of social insurance where you have multiple suppliers, and then you don't have this issue of who pays, because you keep universal care, which they have all over Europe. We're not the only country with universal free access to healthcare. Everybody has that. But they have a completely different model on the other side, in that they have diverse supply, and so there's much more capacity, and you don't have these issues that we have with queues outside GPs and 12-year waits for surgery.
Chris, what about this idea that it's a stepping stone to perhaps another model?
So I think there's a lot of infrastructure required for people to make payments for their care, and that involves a lot of different places collecting money, and that also involves assessment of people's ability to pay. I don't think that will generate the levels of income that will support the system. In fact, I think it will generate unhelpful activity, and what we've found when we look at evidence of some of the co-payment structures around Europe, around the world, is that those who have the least do actually suffer. That in terms of health equalities, these widen.
That's not right.
There are. So in terms, so other aspects that I guess then that I would pick up on is that when faced with payment, either in terms of prescription charges, that some people then don't collect prescriptions for medicines that they would otherwise benefit from, and in terms of access to primary care, we know that there is evidence, there are examples of people delaying seeking medical attention.
Hang on a second, Andy, but do pick up on that point that Chris says it would lead to more inequality.
No, I mean, look, I just think we have to move. We have a long history in this country of telling ourselves that we're doing fine. There is no evidence for this at all. The OECD evidence is absolutely crystal clear. We are not doing well in terms of outcome from killer cancers, outcome from stroke, outcome from heart disease. We don't have anything like as many doctors per head of population, or nurses, or beds, or scanners as other countries in Europe that put in a similar amount of money. We are not doing well. We have to let this go. We always think we're doing okay, and we pick little parts of other services and we say, oh, isn't that terrible? It's not terrible. If we had a structure that worked, other countries would copy us. Nobody copies us. Nobody wants anything to do with a service like ours. And there is no testing of income or anything like that. That does not happen in Europe. There is universal access. But the difference in Europe is that people can pay a little bit more if they can afford to. And in Europe, they don't see that as being elitist. That is egalitarian behaviour in Europe. They think it's their duty to help those who don't have the means by making sure that those who do pay a little bit more.
OK, Chris, what is your big idea? I think we all think that something needs to change. What would you want to see changing?
I guess I'd really hope that we get a chance to know as a country how to use our health services better. I think there is some activity underway around about value-based care, where we, as medical professionals, try and point out what treatments aren't effective, what things are a waste of money, what things might make people worse and still cost the system large amounts. So I think there are things that we can do to change around how we're organised, how we get information across to people, how we make better use of the resources that we have. I think we do still need to be discussing these very many different changes that we could make. But I think we need to look to the evidence.
And we've run out of time to discuss it this evening, but thank you both very much indeed for joining us this evening.